Good evening to everybody. Today's topic for discussion for the nutrition in pregnancy, as you see in the topic of 5 Ws of nutrition in pregnancy. As you go subsequently, you will get the answer at what are the 5 Ws. At the outset, first I have to thank the organizing committee given me chance for speaking regarding the nutrition of pregnancy. First, talking regarding the nutrition, this is the most neglected subject since the inception, since the childhood of your medicine. Because neither at the undergraduate level or neither at the postgraduate level is shown that or anything taught or discussed about the nutrition. This is the most important thing. You heard in the various lectures since yesterday in the workshop and today the morning since CM is going on, so many people talking of each and every disease management, nutrition is a single word. Nutrition is the intervention with a minimal support, either the financially, either the organization, either the teaching level is the minimal support and giving the maximum output or maximum benefit. They shown that out of the hospitals which are admitted to the hospital patients, any general category, irrespective of the specialty, 30 to 40% patients admitted are the hospital having some amount of malnutrition, either overnutrition, undernutrition or malnutrition. And when in the course of the hospital, around 70% of the patients are getting malnutrition. That is the reason why I think the organizers thought the importance of the topic and they given for talking with this. Now, pregnancy represents one of the most profound stress that woman will experience in her lifetime whenever she gets pregnant. Most of the women adapt physiologically with minimal need for the supplementation of the vitamins and minerals. But in rare circumstances, we have heard the various diseases complicating to pregnancy, and really it becomes important for the nutrition. Now, as you see in the round, a lot of discussion will happen regarding various things. You heard about the IV fluids, you heard about the antibiotics, you heard about the various strategies should be for treatment of the patients, what are the various ways, what are the various specialists taking the opinion for doing positive side or negative side. If one of the residents asks, shall we start NG feeds? Then the treating doctor says, let us not complicate the things. This is the regarding the concept regarding the nutrition. As we heard in the previous lecture, everybody talks about you should maintain the balance about the fluid. In the same way, everybody should inculcate the habit of maintaining the caloric balance. In my ICU, own ICU, we maintain the balance of the fluid, sugar and nutrition of kilocalorie every 6th hourly. So that it is proved beyond doubt, any negative caloric balance directly increases morbidity and mortality of the patient, stay in the hospital, antibiotic uses, the days on ventilator and the complications and including the cost of the patient also. So that it is a simple intervention starting early will help in all the ways. There is none of the intervention available till in 21st century. He is having all these advantages with the minimum investment or minimum need for doing it. Now, no other time in the woman life nutrition is so important as before, during and after pregnancy. It includes all 3 stages, that is the preconception nutrient needs, pregnancy increased nutrient demands and lactation nutrient needs. All things are different. I'll clear cut the ideas regarding the nutrition. Most of the people, as you see in the IV fluid also, whenever you talk about the nutrition is having 3 components of carbohydrates, proteins and fats. Most of the people think that giving a dextrose normal saline or 5% of the dextrose patient is NBM, you are giving the things. You are not doing the proper things. One of the other important thing in the patient being in the hospital, it is the gift given by the doctor or the hospital, patient developing a malnutrition. Because patient didn't came to the hospital with the problem of malnutrition, you are not given the proper attention to the patient as a seeing as a whole, and patient developed malnutrition and associated other morbidities. Most of the people you see, they say that I was 100 kg, I entered the hospital and within 10 days my weight reduction is there. In the hospital we are not doing weight reduction program free of cost. Now, if you think about the malnutrition, why it is important to discuss? Because it's having so many side effects, all other problems. They say that what you call in Marathi, one is there, the mulache pay parna distat. It means that whatever going to happen in the adult time, whatever the relation is there for developing a diabetes, hypertension or other genetic disorders, that happens in the preconception period at the genetic level. In that way, the role of nutrition is also important. You see in this slide, in the various stages of the development, In the development stages, you see, it is the maximum in the first 8 weeks of pregnancy of organogenesis happens. Then that is become the stage of development. That is the reason the preconception period nutrition and the initial first trimester is very important for nutrition, because at that main time is the formation of the organogenesis. Once it is formed, after giving the nutrition, it is only for the development of the body, not for any organogenesis. Now, a woman's nutrition intake before and during pregnancy affects not only the growth and development of her baby, but can even have an effect on the fetal malformations also. This is the first statement was made long back. Not only everybody knows about the drugs, by giving this drug or doing X-ray having malformations, even we are not giving the proper nutrition is also the contributing factor causing a malformation of the baby. Now, the recommended weight gain for a normal BMI, body mass index of 18 to 21 for the patient is around 11 to 16 kg. How much will be there they given? Even the underweight, they given increase the weight gain for the person of 12 to 18 kg, more than 2 kg, and for the overweight people, they should not have that much of weight gain. Now, as you see in this slide, the pregnant patient and lactating patient, that is the recommended daily allowances given by the Journal of Human Ecology and the NIN, National Institute of Nutrition of Hyderabad also. Most of the requirements at least twice than the general requirement of for the person. You can see here, including the trace elements, vitamins, and micronutrients also. Now, why to go to from other place? Even in our own state of Andhra Pradesh also, the various people are there from the various strategies of the body mass index of normal, of underweight or overweight. In that also they found they are not up to the mark. In even the society, either the higher society, middle class or lower economic society, where the problem of undernutrition or malnutrition is persisting. Pregnant women with calorie consumption of even what is the current scenario, everybody talks about the Western. We have some literature in India also. The pregnant woman with the calorie consumption of less than 50% of the recommended had a lower serum zinc level compared to the woman who had a higher caloric intake. Results on dietary intake showed that as per increase in the consuming less than 50% of the calorie, protein and beta carotene respectively as compared to the recommended daily allowances even in the higher socioeconomic group also, because of not having the awareness and giving the least importance for this problem. Now, as for the nutrition, we have the two major parts of macronutrient and micronutrient. In the pregnancy, for a normal person, we give around 50 to 70% of the carbohydrates, 15 to 20% of the fats, and 30% of the lipids. One important thing you have to remember, most of the people when calculate for the energy of carbohydrate and fats is included in the daily energy requirement, not the protein. Because protein is given replacement for a bodybuilding or maintaining a positive nitrogen balance. Though in the hospital setup, it is never possible to reach the positive negative nitrogen balance. Because even studies we are reading in the literature or books saying that a negative nitrogen balance affects of the patient outcome, irrespective of the disease or irrespective of the problem or irrespective of the surgery. So that total energy intake during pregnancy increases from 2,200 to 2,500 kilocalorie per day in the course of third trimester and adding off 700 kilocalorie per day during the lactation. Normally, you and me sitting here for the whole conference today must have eaten more than that, but doesn't require that much energy. On average, every person requires around 1,600 to 1,800 kilocalorie. Almost 25 to 30% is more of the normal requirement for the woman. The carbohydrate should, I told about the same thing. Now, regarding the fat requirement are unchanged during pregnancy, ideally saturated fat should be limited and the majority of the fat should be monounsaturated and polyunsaturated. That is long chain PUFA. The long chain PUFA that is containing an DHA. DHA accumulates in the fetal brain in the second half of pregnancy and it is important structural component of the retinal lipids. The physiological importance of DHA is supported by its active and preferential maternal fetal transfer, which is mediated by specific fatty acid transfer proteins and membrane binding proteins that favor the placental transport of DHA, and that is subsequently see that is the important component in the brain development. For this supporting all various clinical studies are there which are happened in India and outside India. They shown that in a randomized clinical trial of fish oil supplementation in high-risk pregnancies, preterm delivery rates were reduced by 46%. Because most of the people never found out. We see for the preterm deliveries or getting missed abortions, everybody do the assessment of the various genetic or various diseases, but nobody knows about because of undernutrition is happening or what. That should be also included one of the evaluation of the parameter of preterm delivery or getting recurrent abortions. A multinational epidemiological study suggests that higher concentrations of DHA in maternal milk and greater seafood consumption are associated with the lower prevalence of postpartum depression. That is one of the major quantity, as on the ICU side we are seeing most of the delivery is over and postpartum patients are getting depression. If they are not given an adequate education how to cope up with the pregnancy, then the problem starts. Observational studies have shown that high content of long-chain PUFA in the maternal diet, particularly DHA, is associated with the better cognitive development and visual acuity in their infants. So that particularly why the people having more understanding, even if you see the 5 kids born in the same hospital, in the same environment, having higher IQ who has consumed the proper diet. Now, protein is essential for the growth of both maternal and fetal tissue. As I mentioned previously, it should not be included in the caloric intake. It is included only in the growth. The effect of protein deficiency on the outcome of pregnancy are difficult to assess because you are maintaining only for the making a nitrogen balance. The pregnant woman should ingest around 1.1 up to 1.5 because in the pregnancy, if you give more protein, it was more of microalbuminuria. So that control the protein intake. Adolescents and women with the multiple gestations have increased protein requirement as because of the logical reasons. Should not be accounted for the caloric intake because compensate of the nitrogen balance. Now, these are the 4 pillars of a healthy pregnant diet. For the brain development, as I told, you require a DHA, choline, iodine and folic acid that should be included in the first trimester of pregnancy. That's the reason even in the ICU setup or anesthesiologist, sometimes you see the patients coming under for laparoscopic surgery or for infertility surgery or for transplantation of the what you call as the oocyte for this thing. That time also if patient is not receiving, please start them. You also have the role for starting it. For the growth, you require a protein, calcium, vitamin D, and carbohydrates and fats. And for the immunity fighting power improving in the mother and baby both, you require vitamin C, E, and zinc. And for the healthy digestion, you require fructooligosaccharides. Now, special groups that are at risk for the undernourishment for the micronutrients, not the micronutrients, are the overweight. Though the person is looking overweight, either 100 kg or 120 kg, they have the deficiency of the micronutrients, not the macronutrients. Particularly the vegetarians on the strict vegetarian diet, the smokers, multiple pregnancy, chronic diseases including HIV infected women, a short birth interval, not maintaining a minimum of 2 to 3 years, adolescents and diminished exposure of the sunlight, though we have the adequate amount of sunlight in India. The specific needs for the fetus vary with each trimester, as told. The protein content of formula feed should be twice of the non-obstetric patient and this supplementation must be carried until lactation continues. Increased amounts of zinc, folate and vitamin B12 in the first trimester. The iron content should be around twice, around corresponding to 4 to 6 milligram per day. A singleton of pregnancy consumes around 1 gram of the elemental iron. Now, regarding, you see most of the pregnancies going on, as we heard about the thing, only 10% of the obstetric patients get an obstetric-related complications or medical disease complicating pregnancy, and that are the patients coming to the ICU and require a special intervention from all your side and support for the better improvement of the baby and the mother. The recent case series suggests that between 0.1 to 0.8% of the obstetric patients are admitted to the traditional intensive care unit. We heard about a lot of discussion about the intensive care unit. This is the general term for the routine intensive care unit. Among these populations, the risk of death ranges from 2 to 11%. This is the single most important entity when the patient is not having any background disease, but is get complication, mortality is very high, irrespective of the medical disease patients. If medical disease of patients comes, they have a lot of comorbidity background and getting a complication, morbidity, mortality high. This is the only special population group not having any background disease and any complication becomes more, so that the chances of death or morbidity, mortality is very high. So that special attention should be given to this group of patients. Hemorrhage and hypertension are the most common causes of the ICU admissions in the obstetric patients. In the last interaction session, panel discussion, you heard about that. Most of these patients typically require relatively simple interventions, monitoring and supportive care, and you can save both the mother and baby. Now, what are the other common conditions other than this? What people have discussed coming to the common ICU, we should have awareness in the mind and should have the knowledge regarding that. The acute respiratory failure, the liver diseases with the TTP, DIC and sepsis, that is the most common post-operative complications, are septic abortions, missed abortions, congenital valvular heart disease, severe anemia, cardiomyopathy, encephalopathy, and another common is diabetic ketoacidosis. So that we should have the idea regarding the management of these patients. Now, regarding nutrition, there are some changes are there that should be accounted for the planning the nutrition plan. Regarding the weight gain of the patient, as I told that in the first trimester of a normal body mass index, how much weight gain is required for the per trimester. Fetal and placental growth, you see on the routine ultrasound screening, how much is there amniotic fluid, how much growth is there, so that additionally you have to supplement from outside. Increased fat stores and serum lipids, increased total body water and increased extracellular volume, dilutional anemia, dilutional hypoalbuminemia, increased clotting factors, that is the reason why the pregnancy called as a thrombotic state, increased cardiac output and renal blood flow and delayed gastric emptying. Now, what are the different variables are there when you are monitoring the patient in the intensive care unit when the complications happens? These are not the same as compared to the normal person, so that you cannot calibrate or equilibrate of the same person, so that management little bit differs in that way. They have, as I told, they have the increased cardiac output, decreased SVR, decreased blood pressure, increased heart rate and decreased PVR. Regarding the respiratory variables, they have the decreased FRC and increased minute ventilation, so that the amount of hypoxia, the time duration required is much less for the pregnant woman than the routine person. Now, since morning you must be hearing about all the variables. I will not go in the detail of the variables, what are the changes and investigations are there, so that you clinically correlate for the patients when you see the investigations. Now, very important, whenever the patient comes to the hospital, as far as for the nutrition is concerned, whenever the patient comes to the hospital, always you do the assessment of the patient. What we follow in our ICU is the first hospital in India to start a good nutrition practice in the hospital. And almost we cover around 100 patients in the hospital of a 400 multi-speciality hospital. And we are doing a pilot basis study, and same is going to present in the international conference also, how much is changing in that. So that while we are doing the nutritional assessment, we have some specific questions to ask, not related to anything of the disease, only related to the nutrition. Then you come to the conclusion of that whether the patient have normal nutrition, undernutrition or severe malnutrition. That is nothing but a diagnosis, how you made a diagnosis of the disease. In the same way of the nutrition also you make a diagnosis. Once you make a diagnosis, then you decide you require a nutritional intervention. In the same way you make a disease diagnosis, you require for the intervention. Once you require for the intervention, you find out how much is the abnormality, how much is the grade is that. Once you do, and then start, that is called as nutritional intervention. Once you do nutritional intervention, you see for the recovery of the patient when the disease having in terms of whether the WBC count come down or fever come down. In the same way, we have the variables to know whether the patient undernutrition or malnutrition problem came down. We do the monitoring over a period of 1 week. Whatever the intervention started really worked or not. If not worked, then what is the next problem or what is the next issue that should be tackled. In the same way, that is the reason we monitor for the indicators like prealbumin and serum transferrin are preferred for the follow-up and assessing of the response of the nutrition support. Or if we have doubt whether the patient are normally nourished or undernutrition, we can send the level of prealbumin. There will be no confusion of serum transferrin, and your diagnosis will be clear whether you are dealing with a normal nutrition or undernutrition. Now, when you are planning a diet, as I told, it should be a combination of all, neither only the 5% dextrose you are giving IV fluid. It should be a combination of adequate carbohydrates, proteins, and fats, and micronutrients. Now, nutrition assessment of the patient is done, as I told, we follow the global nutrition assessment. We have that, once that nutrition assessment comes that it is a normally nourished patient, we can start a normal feeding, but a combination of total of the combination of carbohydrates, fats and proteins with a combination of requirement of the micronutrients. If the person is normal nourished but will develop malnutrition because of disease process if support is withheld. Suppose any patient came off postpartum hemorrhage, patient is on ventilator, patient is on continuously bleeding going on, patient is in DIC. For next 5 days or 1 week, you are not able to start nutrition. That is the person at risk for getting a malnutrition in the hospital environment. These are the patients you should target for the nutrition therapy. Or the patient already a malnourished, we can start a nutrition support, what is indicated according to your calculation. Now, once you decided that your nutrition support is indicated, then always one dictum is there. If gut is working, use it or lose it. Okay. Always normally try to use the gut, that is the normally functioning. If not working it, then you use that alternative route. But first, always you try for enteral nutrition. Don't go for high-fi of parenteral nutrition or central nutrition or TPN or partial parenteral nutrition when not indicated. The same thing when person is not able to take adequate, whether we can put a feeding tube and we can start a nutrition. That is also important. Is the oral nutrition possible? If answer is yes, go for the normal feeding along with the supplements of the dietary, which are the deficiency you think are on your investigation or history wise. If no, does the GI tract function adequately? Either the person having nausea, vomiting or loose motions is not adequately performing, though you can give a double dilution formula or bulk forming agents. If still not using, then is the only criteria to use, go for a partial parenteral nutrition. Now, does the GI tract function adequately? If no, normally nourished, we can give for the parenteral nutrition to be considered over a period of 5 days to 7 days afterwards. If no, in patient is malnourished, then straightway you have to start for the parenteral nutrition. If yes, we can go straight for the tube feeding. And you think that patient is mildly or moderately malnourished, then you have to combination of start the tube feeding plus parenteral nutrition. That's called a partial parenteral nutrition. Now, as you told about the routes of nutrition, the decision should be taken by the multidiscipline of the obstetrician, intensivist, and involve the clinical nutritionist also. Enteral route is the first preferred unless it is impracticable, ineffective, and intolerable. Then and then only the route should be changed. When considering enteral nutrition, maternal gastric emptying and risk of aspiration and regurgitation should be kept in mind. So that whenever you start nutrition, irrespective of the disease, always start the nutrition in the proper position, so that chances of aspiration will be less. Enteral nutrition delivery should be slow, because we know that should not give the bolus feeding, always give the continuous feeding of the small and over a period of long time, because we know that as a pregnancy itself, you have the gastric prolonged duration of the entry, and because of the various drugs, because of the opioids, because of the dyselectrolytemia, bowel will not moving. Always give continuous feeding, not the bolus feeding. Parenteral nutrition should be considered when enteral nutrition is not possible and adequate. Parenteral nutrition, most of the people have the confusion, parenteral nutrition should be only given by the central line. No, it is depending upon the osmolarity of the solution, because most of the parenteral nutrition with higher kilocalorie, osmolarity will be high. Whenever any osmolarity will be high, if you have vein, it reacts by formation of thrombus, thrombophlebitis. In the same way, we puncture the artery. In artery injury, it reacts by spasm. In the same way, if you irritate the vein, it reacts by formation of thrombus or thrombophlebitis, and itself is the cause of fever in the ICU, causing an infective thrombophlebitis. Now, what are the special cautions of enteral nutrition in the obstetric patients? As I told, the advantages of enteral nutrition when compared to the parenteral nutrition are far too many, and it must be the mode of choice whenever possible. Because whenever we using the enteral nutrition using the normal route, it is inexpensive, easily available, no need of many complications or special nutrition or neither the finances. Because it is the fuel for the enterocytes or the lymphocytes which are there in the gut, so that maintains the gut integrity, and at the same time your prevention of translocation of the bacteria from gut to the systemic circulation and causing a bacteremia and fulminant sepsis. A critically ill obstetric patient is more likely to reject enteral feeds and develop constipation due to the relaxation effect of progesterone on the bowel smooth muscle. That is the change and the normal person. The chances of aspiration can be minimized by ensuring a semi-recumbent position while administering enteral feeds and routine radiological confirmation, if possible, of the position of the nasogastric tube. Always, whenever the critically ill patient is there, always whenever you do either intubation, you put a central line, always take X-ray. In the same way, whenever you put a nasogastric tube, because of radiological marker, always do an X-ray. There are enough number of case reports, enough number of showing the anecdotal reports showing that nasogastric tube was not in proper place, patient got an aspiration and complications. So that make it a habit whenever high risk patients are there, particularly obstetrics, severely obese patients, trauma patients. Whenever you put a feeding tube and whenever doubt is there of difficult airway, always take a X-ray and confirm the position of the tube. It will save you medico-legally also, because it is one of the complications medico-legally if you are giving the feed to the lung. To combat and reduce the motility, a prokinetic agent should be always added frequently. Whenever most of the time we see frequently asked question, our gastric residue aspirate is more than 200 or 500, what to do? Stop the feed. Never stop the feed. That is not indication for stopping the feed. Only you can come down on the feed of 50%, give double dilution formula, find out why the cause is gastric residual aspirate more, add a prokinetic agent. In spite of doing all the interventions, still gastric aspirate is high, or patient developing signs and symptoms of subacute intestinal obstruction, that is the indication, only stopping the feed. In our place, even after the post-operative, having GI anastomosis, we start with RT feeds after 8 to 12 hours of the surgery. There is no contraindication. we have the good number of series not having perforations, complications, peritonitis, no other problem is there. Even if you are not giving nutrition, whatever the juices which are secreted by the intestine is not stopped. That is the RTS plate, you can see the bile is coming, gastric juices are coming. Then what is the problem in giving nutrition? So there is no contraindication for giving nutrition even in the immediate post-operative period. They are having their own advantages. If you use it, and have that courage to use, definitely you will be successful than the other patients. It is recommended to use anti-aspiration prophylaxis routinely in the form of H2 blockers or proton pump inhibitors. Now, what are the special concerns regarding the caffeine? It should be have limited intake during the pregnancy. Excess caffeine can cause interfere with the sleep and contribute to nausea and lightheadedness, can increase urination and lead to dehydration itself. Regarding the vegetarian diets, particularly if you take the history, they are vegetarian or non-diets, they will have the deficiency of the iron, vitamin B12 and vitamin D. Because the coffee you take more, you have the decrease in the iron absorption, may reduce the blood flow through the placenta, a risk of spontaneous abortions with heavy caffeine use, so that we should restrict the use of taking coffee less than 2 cups per day. Now after this, all this asked, that is the sample diet for a normal pregnant patient, we can use it. It should be a wholesome of diet of combination of all the things. Now something talking about everybody's query, everybody's doubt and everybody's complications thinking about the parenteral nutrition. It is indicated or not? Yes, it is indicated parenteral nutrition even in the cardiovascular disease, whether the patient have hypertriglyceridemia, all indications it is indicated, provided that you are monitoring the level of triglycerides. If it is not going above 400 or 500, we can go continue with the parenteral nutrition. There is no contraindication for giving parenteral nutrition. The target is not only to nurture but provide adequate calories and nutrients for the growing fetus. As I told, in the parenteral nutrition also component, we have the carbohydrate of 60 to 70%, fat of 30 to 40%, and protein double of the adult requirement. The nutritional goals must be adjusted on the basis of associated elements. Now, regarding the calculation of the energy, how it comes, whenever you calculate the energy, normally the fluid requirement for the person is around 25 to 35 ml per kg. Is including your IV fluids, including your nutrition, including dilutions we use for the antibiotics, and that you have to divide how much to give. Usually use an isocaloric formula, 1 ml equal to 1 kilocalorie. Give continuous feed over a period of time. The use of inotropes may increase the caloric requirement by 2.5 times. When the patient having hypotension of a pregnant patient, definitely the caloric requirement increases. In that you have to increase the caloric requirement by the 2.5 times. With each degree Celsius rise in the fever, the caloric need increases by 10%. The patient having fever, irrespective of the temperature of more than 100 degree Fahrenheit, we should increase the caloric intake of more than 10%. Sepsis may increase the basal need by 1.9 times than the basal requirement in pregnancy. Now regarding the parenteral routes, we can have the central route or peripheral route for giving an parenteral nutrition depending on the osmolarity. Any osmolarity of more than 800 or 900, that is nothing but 3 times of normal plasma osmolarity. Always use a central line for giving your parenteral nutrition. The traditional central venous access is infraclavicular because of the obvious reasons, less chances of complications, easy to manage, easy to use for a longer time, easy to take care also. Now regarding the peripheral nutrition, short-term peripheral nutrition for infusion over a period of 1 week to 10 days. For solutions with osmolarity obviously less than 800 or 900. When central catheterization is impossible because of the patient having trauma and surgery of the upper part of the body, or patient having central line related or CRBSI, central line related bloodstream infection. In the adult, catheters with a caliber of 18 to 22 gauge are commonly used. Catheters with a length of less than 80 mm have a universal Uhrlach connections. It is recommended to use first the peripheral veins which are distally located on the hands of the arm. Veins of the feet or legs should be avoided due to the high risk of septic and thrombotic complications. Now the advantages of the peripheral nutrition than the central nutrition because it's simpler and quicker. No need of central venous insertion or no chest X-ray required because of the pregnant patient have the risk for the exposure for the X-rays. Low risk for catheter-related sepsis and increasing the chances of nosocomial infection in the hospital. Lower risk of complications associated with arterial puncture causing pneumothorax and other problems, and it is more cost effective. As you see regarding the nutrition, we have the various products you see in the outside in the stalls also, but recently the ASPEN guidelines and ISPED guidelines are recommended 3-in-1 use bag. not using the multiple bottles. Because for this, you require an unilaminar flow. And I made the first statement, nutrition is combination of carbohydrates, proteins, and fats, not giving a single bottle. So that always use 3-in-1 system, that is causes improved safety, saving the hospital time and money. Microorganism reproduce with more difficulty than a lipid alone. Because ideally, when you prepare the combination of the lipid, you should have unilaminar flow. And most of the hospitals, even the 5-star hospitals in India, they don't have the facility for unilaminar flow, specifically for the nutrition itself. Optimal peripheral parenteral nutrition, metabolic advantages, less fluctuations in the blood glucose level and the insulin production. Safe, efficient, and well tolerated, increased patient convenience and satisfaction. Now, when to stop therapy? Whenever any disease happens, we start antibiotics, other therapy. In the same way, when we started nutritional intervention and nutrition therapy, when to stop it is also the important thing. When the patient should demonstrate the ability to tolerate and utilize enterally administered nutrients or to ingest and utilize adequate oral nutrients, almost 75% of the daily requirement or the calculated energy requirement caloric need. If daytime oral nutrient intake is suboptimal, it may be supplemented by the nocturnal administration of specialized nutrition support. And adequate oral nutrition intake should be documented on the paper patient is having, not only seeing the things. Now, regarding the other thing, the RT feeds also, if adequate goal of energy intake is not fulfilled in one day, you can continue the rice feeding in the night also for targeting your completing your target of energy goal. Now, the parenteral nutrition in the obstetric patient, the long-back study done in 1990, it was sufficient favorable clinical experience over the last 10 years suggests that parenteral nutrition is a relatively safe and effective method for reversing the maternal malnutrition and promoting normal fetal growth and development also. This is how the nutrition has gone through the ages and where we are now. Thank you. If any question, any doubt, you can ask. No.